Hey, but of course, the top story we've been watching here, the layout and the plans to roll out vaccines here. A CDC panel set to vote today on rollout plans to answer who will get the vaccine first. Over that timeline that Vice President Mike Pence has laid out of about 2 weeks in getting vaccinations started, panels expected to weigh in on who is expected to get that first. Of course, frontline healthcare workers top of mind, along with residents in nursing homes and other long-term care facilities. But let's kick off our coverage here in the second hour with a focus on just that story with our guest today. Dr. Ebony Jade Hilton is GoodStock Consulting co-founder, medical director, and associate professor of anesthesiology and critical care medicine at the University of Washington. And Dr. Hilton, appreciate you joining us to chat today. I mean, when we talk about this has been what we've all been waiting for here. And Vice President Mike Pence saying it's going to be happening in the next 2 weeks here. So what are you expecting to see with this rollout of these vaccines and how it should go in your mind?
Yeah. Well, thank you for having me. With this idea of a vaccine, it is the light at the end of the tunnel. But what we do know is that there's only a few available. Pfizer, for instance, which should be the first rollout, will have enough doses for about 20 million people. Moderna, maybe 10 million people in December. But what we know is that there's 20 million healthcare workers. There's 50 million people that are over the age of 65, 100 million Americans with pre-existing conditions. And so how do we make sure that this is done with the lens of equity, that those who are at greatest risk of not only getting infected, but also dying are actually being made available for these interventions first?
So what does that equitable distribution look like?
Right. So I think we have to look at the numbers. You guys are big into financial numbers. I'm big into disparities numbers. And what we know is that African Americans, for instance, are dying at 3 times the rate of Caucasian Americans. We know that Latino Americans are also dying at 3 times the rate of Caucasian Americans. So looking along the lines of race has to be put into this category, but also age. We know globally that those who are 65 and older make about 9% of the global population, but they account for about 30 to 40% of all COVID-19 cases, right? They make up about 80% of all those who have passed away from COVID-19. And so when we're thinking about how to distribute this first, I do think we need to consider our healthcare workers that are going to be face to face with these ever climbing cases. But also, we have to be very targeted on certain groups and population. Those are going to be those of racial minority groups, those are older population, and those with the pre-existing conditions. Once we have those big three buckets of people vaccinated, then I think we can go into the less riskier populations as we continue to do the basic simple precautions of wearing our masks, washing our hands, and avoiding any large crowds of people.
Yeah, looking beyond, I guess, the first rollout of the vaccines that we're going to be seeing here in short order, there are questions as you're talking about equitable distribution. Beyond that, there are also concerns that Americans, largely in those communities of color, which have not gotten flu vaccines in terms of the percentage that we've seen from white Americans, what can be done on that front. So when you look at this and you weigh those concerns and you weigh the concerns that the actual health staff workers here in this country might not be enough, what kind of boost are you expecting to see here from government efforts to really maybe roll this out and not just having doctors and nurses here, but also pharmacists, other medical workers coming on board here to help get this vaccine out to millions and millions of Americans?
Right. I think the main thing is we have to be intentional. The reasons why minority communities aren't necessarily getting vaccinated isn't all put on what we call the trust or mistrust of the system. I don't think it's only that. I think it's literally lack of access. With COVID-19, we saw the testing, that the lack of access or the ability to be tested was literally disproportionately impacting communities of color, that the testing centers weren't placed within those zip codes. And so moving forward, we have to have this intentional idea of how do we make sure we bring those vaccines to those communities. When we're looking at Pfizer, for instance, with their vaccine, we know that it's going to have the obstacle of having to be really, really cooled down to negative 90, negative 70 degrees. And therefore, they're going to have to be certain systems in place to make sure that happens. If we know that to be true, and we've known that to be true now for months, where have these developments been made that are going to place those areas of this cold distribution into those communities? Have we put money and resources to make sure those rural communities, those urban communities, will have those storage units made available to them? And so I hope with the next administration, we start to be proactive in those measures to say, let's do it now so that we're not still trying to play catch up come April, May, and June of next year.
Doctor, a big part of making sure enough people are inoculated is convincing them to get it. And on that front, there's been a lot of concern about the safety of these vaccines. You've specifically pointed to concerns around the diversity of the trial. How comfortable are you when you look at a Pfizer or a Moderna in terms of the types of trial they've conducted and the diversity in the patients they have tested?
Right. And, very early on, Moderna, for instance, made a big push to say we need more diversity along the lines of race in particular, that we need more participants to agree for these trials. And we know historically why there was a mistrust in the African American community in particular to the medical community. They had reasons. Tuskegee was not that long ago. It literally ended in 1972, 10 years before I was born. We know the happenings of Flint, Michigan that are happening still today, where we have these distrust of the system and doing what's best for the people. So moving forward, I think the medical system, we owe it to the people to prove to them that they can trust us. And whether that is us being more transparent and us showing us getting the vaccines ourselves, that's one of the avenues that I've actually explored to show patients and to show my community that I'm willing to do this to me so that we can keep you alive. And I hope that in sharing that vulnerability with people, that they may be able to say, okay, I trust it a little bit more too for my body if they're willing to do it too. So it's going to be those efforts of truth and transparency and truly communicating with the community and not at the community is what we have to start doing from here on out.
That's important. And Dr. Hilton, I should also note, I think I owe you an apology. I introduced you as a doctor from the University of Washington, and that was a mistake because you're from the University of Virginia. As a former Virginia boy myself, got to correct that. Maybe it's because I'm a Hokies fan. It could have been subconscious. We'll see. But Dr. Ebony Jade Hilton, Associate Professor of Anesthesiology and Critical Care Medicine at the University of Virginia. Appreciate you joining us.
Thank you so much.